Hello, good morning, everybody. 大家好吓。咁咧就Doctor, may I introduce our speaker for this session? Dr. Lorenda Guan Chang, 關陳立穎博士 is a speech therapist, university lecturer, and researcher. Her work focuses on the assessment and intervention of speech, language, and swallowing disorders associated with Parkinson's disease, dementia, and stroke. Dr. Quan Chang is currently a council member of the Hong Kong Parkinson's Disease Foundation, HKPDF. She speaks regularly in HKPDF seminars, workshops, and writes articles for the Hong Kong PDF Bulletin. With the support of the Community Rehabilitation Network for the Hong Kong Society for Rehabilitation, Dr. Quan Chang has instituted and conduct extensive hybrid speech teletherapy for the community. In this talk on exploring frontiers in speech therapy for Parkinson's disease, Dr. Quan Chang will describe the complexity of speech impairment in Parkinson's disease and the impact of speech by multiple factors associated with motors, non-motor impairments, and the medical intervention of Parkinson's disease. She will present the latest aspects of assessment and intervention of speech disorders in Parkinson's disease that is crucial to clinical service. May I now invite Dr. Quan Chang to present her talk, please.
Hello everyone, the topic for today is Frontiers in Speech Therapy for Parkinson's Disease. I'm the speaker, Dr. Lorenda Guan Chang, and my speech therapist practiced for more than 25 years in these areas. I'm currently also a university lecturer and clinical educator, also a council member of the Hong Kong Parkinson's Disease Foundation. I have nothing to declare. The topic will be divided into two. So the first half will be on the speech impediment, or we call it dysarthria, in people with Parkinson's disease, the way to assess it and the way to manage it. And then the second part will be focused on swallowing disorders, also called as dysphagia, in people with Parkinson's disease, together with also the way to assess it and to manage it. The first part, dysarthria in Parkinson's disease. Dysarthria is basically defined as the motor speech disorders associated with neuromuscular muscle weakness. About 90% of people with Parkinson's disease are affected by dysarthria along the disease progression. And we understand that even at very early stage of Parkinson's disease, people do suffer from speech impediment, and it complex their health-related quality of life and impact on the communication participation in the affected individuals. The speech impairment, as we understand, is a interaction between the motor and the non-motor disorders found in people with Parkinson's disease. It is slowly degenerative in nature, start quite early on when at the very beginning of Parkinson's disease and gradually become more severe as together with the advancement of Parkinson's disease. We also know that perceptual features is not very easy to pick up the impediment in the early phase of Parkinson's disease. However, instrumental acoustic measure will be more sensitive towards the changes in our voice and articulation. This is a figure of the anatomy and physiology of dysarthria in Parkinson's disease. We know that the anatomical substrates of this speech production involve these three areas, and the speech components in the speech production involve articulatory, rate, and prosody, phonatory, and respiratory components. So which speech components are affected by Parkinson's disease? Basically all of them, and I list them all. Here are the articulatory accuracy, speech rate control, prosody, that includes the intonation for differentiating questions and statements, as well as the emotional prosody, the lexical tones, the rhythm, the phonation of voice, the loudness. These are the terms used by speech-language pathologists to describe errors or variation in these speech components. They are namely dysarthria, anarthria, dysrhythmia, dysprosody, dysphonia, monotone, and monoloudness. In addition to the anatomy and physiological circle, we also now understand more about the neurological base of dysarthria. As we know, speech production is controlled by these brain parts, namely the basal ganglia, primary motor cortex, dorsolateral prefrontal cortex, pre-SMA, thalamus, brainstem, cerebellum. So any disturbance in this neurological circuits will result in impediment of speech. The reason why neurological based understanding of dysarthria is important to speech-language pathologists or speech therapists is the reason that we now observe the dysarthria found in people with Parkinson's disease are complex, and it is more than the classic hypokinetic dysarthria that we used to know. And nowadays we understand that even in people with Parkinson's disease, you may also notice the presence of spastic dysarthria and ataxia dysarthria. So how do clinicians diagnose dysarthria in Parkinson's disease? The major way of doing it is through a gold standard developed by the Mayo Clinic in about 1960s. So there are three researchers, the Daly, Harrison, and Brown. They set up a perceptual features framework to decide whether or not a person is suffer from dysarthria. So these perceptual features include features of prosody, speech rate, articulation, phonation, and voice quality. And the more we understand about speech impediment in people with Parkinson's disease, the more advanced ways that we are developing to make the diagnosis more accurate and sensitive. So the acoustic features come in later with the advancement of spectral analysis, and we now use spectral features such as fundamental frequency, intensity, harmonics to noise ratio, substrate prominence, speech and articulation rate, voice onset time, and formal frequency determine the presence of dysarthria. These are the classic perceptual features of the dysarthria, which is called the hypokinetic dysarthria in people with Parkinson's disease. That include reduction in loudness, monotone, monoloudness, loss of stress, low pitch, slow speech rate, short utterance length, imprecise articulation, high pitch breaks, accelerated speech rate, stuttering like disfluency, inappropriate silences, repetitive speech sound disorders, and poor voice qualities. The clinicians will have to decide whether or not some features present or absent, and if they can identify some of the perceptual features, we group them together to make a diagnosis whether this is a dysarthria that is classically found in people with Parkinson's disease. The second way of doing diagnosis is through the acoustic analysis, and these are the acoustic signatures of dysarthria in people with Parkinson's disease, namely the short maximum phonation time, reduction of mean intensity, reduction of mean fundamental frequency, reduction of variability of intensity, reduction of variability of F0, change in speech rate, articulation rate, long pause time, change in voice onset time, change in phoneme frequencies, change in harmonics and noise ratio, and change in values of sexual peak prominence. Acoustic features can be very useful to determine the presence of dysarthria. So useful now these days, people are suggesting using acoustic signatures as the biomarkers for Parkinson's disease and to measure traces for its disease progressions. Also, we found that different types of neurodegenerative degenerative disease will use different acoustic signatures. And here is a graph of how we can use acoustic signals to determine whether the person is more having a idiopathic Parkinson's disease or PSP or MSA. Here are the list of the types of dysarthrias as associated with the major type of neurodegenerative diseases like Parkinson's disease, PSP, MSA, spinal cerebellar atrophy, Huntington's disease, and multiple sclerosis. Now, we also find language impairment that could be associated with Parkinson's disease. This is a paper that summarizes the findings of latest research on language impairment found in people with Parkinson's disease. Okay, so what are the factors that will impinge on dysarthria in Parkinson's disease? There are a few of them, namely the stage of PD, types and number of movement disorders, types and number of non-motor disorders, medication, deep brain stimulation, speech load, language load, and cognitive loads. We group the factors in three. Okay, the first group, the stages of PD, and is quite straightforward to understand that the more advanced the Parkinson's disease, the worse the motor speech control. Okay, and that the presence of more than one movement disorders like rigidity and dyskinesia and all the bradykinesia together will actually impinge more heavily on the speech production than the occurrence of only one movement disorders. Also understandable is the presence of more than one non-movement disorders, like a person with both cognitive decline as well as sleep disorders associated with Parkinson's disease will present more severe motor speech disorders. The second cluster of factors that impinge on the speech performance in people with Parkinson's disease are related to the task. So task complexity, which kind of conversation topics the person is speaking. Familiar topics will be more easier for them to produce clearer speech. And whether these tasks are very complicated, require a very quick response time, or whether these topics are very unfamiliar to them or require more planning of speech, or whether the listeners are familiar with the dysarthria person's speech styles will totally affect on the total speech intelligibility of the person. We understand that the perceptual severity of dysarthria in Parkinson's disease are related to the presence of non-motor symptoms, the presence of motor symptoms, and also as well as the presence of different intervention strategies, namely whether or not that person is taking level dopa or whether or not is having a deep brain stimulation. We will talk about it in the coming few slides. Okay, so the common way to manage dysarthria in people with Parkinson's disease are these three, namely the medication, deep brain stimulation, and non-pharmacological therapy. As we understand that a major type of medication is levodopa for the anti-Parkinson medication, and there are long-term and short-term effect of levodopa for people with Parkinson's disease. Short-term impact of levodopa on voice quality has been proven to be positive, meaning that there are benefits of taking levodopa right at the beginning of the disease, and it actually improves the voice quality of the affected individual. How about long-term impact of levodopa on speech? This recent research has demonstrated 12 months use of levodopa has a good support to the speech phonation and the speech prosody in people with Parkinson's disease. The other way of common medical intervention of Parkinson's disease on deep brain stimulation, we understand that there are several types of deep brain stimulation that takes place in Hong Kong, and the most common one is the subthalamus nuclei deep brain stimulation. The other one is, and it's usually done in bilateral way, and the stimulation algorithm, we'll talk about it and how it will affect the speech production at the end. Okay. A recent paper suggests that intraoperative dysarthria is associated with postoperative dysarthria in STN-DBS, meaning that there is a sweet spot for people, for a neurosurgeon to put a stimulator in along the subthalamus nucleus, where the speech outcome could be actually modulated. And according to this paper on 400 cases of people with STN-DBS, and they found out that there is actually algorithm of DBS that facilitates speech production. Basically, our understanding is low frequency setting at 60 Hertz will increase the vowel spaces, meaning that it will improve the overall speech intelligibility in speakers with Parkinson's disease, even though they are fitted with deep brain stimulators. Speech therapy for dysarthria is the most common way of intervention of dysarthria in people with Parkinson's disease. There are 3 ways of doing speech therapies available to us. So the first way is to mainly focus on therapy of the vocal loudness. So loudness is the target, and people come in to do louder sustained phonation, louder sentence production, louder verb, single word production, and louder passage reading, and louder conversation. And then the other way, which is quite a new way, is focus on speech, language, and cognitive communication in stepwise therapy. So the person come in just receiving therapy, focus on more than loudness. So it will be speech and language production in more complicated speech tasks that involve conversation and dialogues and monologues. And the last one will be a focus on intervention of listeners' perception of speech clarity. This is a graph illustrating how the CP perceptual peak prominence improve after the training of a therapy that focus mainly on speech, language, and cognitive communication. And this is also the voice-related quality of life measurement self-ratings improvement after the same therapy has been done. So these are the enablers of the speech therapy for people with Parkinson's disease, telling us which are the factors that we have to pay attention to if we have to attend a good speech therapy for people with Parkinson's disease. Basically, the therapy that are enablers have to consist of these factors. Specificity, whether the speech therapy is targeted for speech or non-speech. The more speech targets, the better the outcome. Whether they target on the dysarthria that can be found in people with Parkinson's disease or not found in Parkinson's disease. So as we understand, the hypokinetic dysarthria is the major type of dysarthria that we find in people with Parkinson's disease. whether the therapy is matched with the advancement of the disease progression of Parkinson's disease, whether the therapy on people who are optimally medicated, whether the therapy on people who has been done with DBS, and if the DBS are at their optimal simulation algorithm that were conducive for speech production, whether or not the therapy is structured and conducive to motor speech performance, whether or not the speech therapy is highly intensive, whether or not the speech therapy target for more complicated task hierarchy involving linguistic and cognitive hierarchy as well, and whether or not the therapy is have extra support for people with Parkinson's disease, dementia, or other non-motor symptoms that you can find in speech in people with Parkinson's disease. As we know, intensive therapy is really a critical factor to determine the therapy outcome of speech therapy for people with Parkinson's disease. We have utilized teletherapy to make sure that the therapy can be done intensively. So teletherapy for Parkinson's disease has helped us to reduce the barriers in geographical and transportation, disease-related barriers, communication-related barriers, and socio-economical barriers. And we may understand that the current situation of COVID-19 actually is help us to develop teletherapy specifically for people with Parkinson's disease to the intensity that they require. We now have accumulated more than 1,000 hours of clinical practice on people with Parkinson's disease through teletherapy. The second part of the talk is on dysphagia, swallowing disorders in people with Parkinson's disease. Swallowing can be impacted by the presence of Parkinson's disease. About 95% of people with Parkinson's disease are impaired in their swallowing functions. The result of dysphagia are written down here. Okay, so it will include malnutrition, dehydration, non-compliance of dosage of medication, aspiration, pneumonia, decrease in social connections, drop in the quality of life, and increase in caretaker burden. Here is a graph that's showing to us the impact of dysphagia to individuals, and that the impact is heavily on their general health-related quality of life and depressions. We can see that correlation is moderate in their scales for the health-related quality of life as well as depression. And we also have to pay attention that this correlation is independent of the disease duration or the severity of the disease, meaning that although the patient may be at the very beginning of Parkinson's disease or the severity of Parkinson's movement disorders, Parkinson's disease related movement disorders are quite mild, it can actually impact on the swallowing to the extent of heavily impact on their health-related quality of life. The management of dysphagia in Parkinson's disease of the in the area two aspects. One is on the active training, and the other is compensation. Active training meaning that the patient will have to do swallowing practice, and such as effortful swallow. They have to do movement of lip and jaw training and muscle strengthening exercises. They also have to do practices on strengthening their cough so as to protect their airway in case that food really accidentally drop from the food pipe into the windpipes. The other way of doing intervention is by compensation. So people with dysphagia will be recommended for different strategies, compensate by food intake methods such as oral intake or tube intake, postural intake such as having food while you tuck your chins, or using a timing method that a person will have shorter meal times but a more frequent meal across the day of the time. A very common way of alleviating dysphagia in people with Parkinson disease is to change the food consistencies. Thicker food consistency is considered as more safe for people with Parkinson disease. The other is to compensate by different feeding skills. So if the patient is cared by a caretaker, speech therapists will make sure that the feeding skills is appropriate to the timing, to the way of swallowing, and to the endurance of swallowing process of the patient with Parkinson's disease. The other way of compensation is to replace some oral form dosage of medication into like a liquid form or a skin patch, or using a gel form that is being placed as an enteral intake of the oral dosage, or as a drug dose intake. So these are the different ways of replacement of an oral dosage form of medication in case patients do suffer from dysphagia that is very severe and prevent them from taking pill form in medication. So that is the end of this session. Thank you for your attention, and I appreciate your attending this seminar, and I welcome different questions from the audience. Thank you.
Okay, thank Dr. Lorenda Guan Chang for her wonderful presentation. Any questions from the floor? Any questions from the audience? Okay. Oh, Dr. Lorenda, may I have a couple of questions for you?
Thank you.
Okay. What are the greatest challenges for assessment and intervention of speech disorders in late stage PD patients?
Okay. Let me repeat your question because I'm not hearing quite well. So, what are the challenges for assessing an intervention for speech disorders
Yes.
for people with advanced stage of Parkinson's disease? Is that right?
Yes.
Okay. So, it's $1 billion question. So, basically, advanced stage of Parkinson's disease, meaning that both the motor and the non-motor disorders are at their peak. So people, that means H and Y stage will be like 4 to 5, and at that time the speech disorders will be really severe. So the term that we use is dysarthria, and at that time both the nature, the type of dysarthria and the severity of dysarthria are at the peak. So we are not talking only on hypokinetic dysarthria. We're talking about a mixed dysarthria. And so that is a challenge to assess because you have to understand what kind of a dysarthria are you assessing. And a lot of people suffer from very severe dysarthria, actually become mute. So there's nothing to assess. So there's very little things for you to assess. Then for treatment, that means that you are basing on non-vocal, non-verbal communicators. So the patient may not be able to talk, and so you have to provide a way that replace oral communication, which is quite difficult because the choice of non-vocal, non-oral communication really depends on the person's cognitive resource. So say for example, the most common way to manage non-vocal communication is by communication board. However, a person will have to have certain kind of cognitive linguistic ability before they can benefit from the use of communication board. So I would think that there is no one way to handle it. It must be a cluster of a group of strategies to handle it. And the more we understand about Parkinson's disease, the better. So that's my quick answer to your question.
Oh, thank you. And then we know that in the past 2 years, we all affected by the COVID-19.
Yes.
And I'm sure the PD patients must be also. How did the COVID-19 global pandemic in the past 2 years impact on the speech therapy for PD patients?
I think that related to my slides, the part of the talk that I just presented is actually we have developed teletherapy to a more extensive scale. So the reason is teletherapy for people with Parkinson's disease has been developed in places other than Hong Kong for quite some time. And the statistics is like 9 out of 10 people with Parkinson's disease in places other than Hong Kong receive speech therapy via telehealth. And we are quite, before the COVID-19, we are actually quite backwards, quite lagging behind. And so after 2 years, 2 or 3 years of development of the COVID-19, we know that teletherapy is actually more helpful, direct for people with movement disorders and during the time of pandemic. So I would think that is actually from the past 3 years, as I said, we have been able to practice accumulatively for 1,000 hours on telehealth for people with Parkinson's disease, and we are actually more skillful in to conduct speech therapy via a hybrid mode for people with Parkinson's disease. So that's my quick answer to that question.
Well, actually, there are 2 questions from the audience. The first one is, what are the cognitive communication training you two will suggest for speech therapists?
Okay, the cognitive communication training is done through multiple tasks. So one common way is on doing monologues. So in order to express a monologue, like for example, about my first day of job. Okay, so tell me about your first day of job. And that person have to use attention, focus, memory, okay, and also organize a script to tell the people about my first day of job. So I'm training through these monologues. It is quite a direct way to enhance both cognition and language skills together with the speech. So we know that cognition, language, and speech cannot be separately into 3 discrete functions, but rather is actually enhancing one another. So if the therapist is paying attention to all these 3 areas, the outcome of the therapy can be more functional to the patient who receives the speech therapy. So that's my reply. There's another question, right? Can you?
Oh, okay. Yes. Well, the last question for you. can you explain a bit more on the direct treatment for improvement cough strength, or is it mainly done through expiratory drive training like EMST?
I think EMST is one of the way. So we do have other ways. Okay, so EMST is through blowing through a resistance. Okay, and by doing that, the direct training is on the expiratory respiratory muscle. So that is the one way, and we know that cough actually is a complex, even though it's a reflexive function, it does involve not just expiratory respiratory muscle. So the ways that we can develop are more can be addressed to different mechanism of cough function. So well, time is short for me to explain more about that, and happy that if you can leave me your email, and then I can try my best to address that in more details.
Okay, thank you. Well, may we all thank Dr. Guan Chang for her amazing and informational presentation. Thank you.
Thank you. Thank you so much. Thank you. Take care.
Yeah, you too.